Hello, Brian. Can you
Hi,
hear us?
who
This
is
is Ajit
this?
Bhagwat.
Hi, hi, Ajit. How are you?
Fine, fine. I have two chairperson along with me, Dr. Anthony Gershlik and Dr. Nicholas Ambile. Will you please tell us about the case, Brian?
Yeah. Ajit,
Can you see us?
yeah, can you see us?
Yes.
Can you see us? We have with us over here Dr. Anand Rao, who's to my right. Further to my right is Dr. Ankit. We have Maruti as our technician, and we have a lot of our staff over here. So good afternoon from Mumbai. Sorry, we are a little bit delayed, so we did some of the stuff already. But this is a 57-year-old man who presented with effort angina for the past 6 months. Over the last 2 months, his angina has increased quite significantly, and he had a stress test that was done in October. He doesn't have the stress test reports with him, but his stress test was quite positive. That's what he said. And then he went ahead and himself did a CT angiography. The CT angiography showed that he had a very proximal LED lesion, which was about 75 to 80%, and he had a mid LED lesion, which was about 60 to 70%. He also had a small ramus branch which had a near total occlusion, and his right coronary artery was not significant at all. Big artery, but no disease. So here we are posted, and then we did some angiographic shoots, and this is what we will show you now. Uh, Ajit, you can see the angiography?
Yes.
Hello? Yeah, okay. So this is the first view that we did in caudal. Now this is the cranial view, and we discussed whether that was a septal or not a septal, and we thought that this was more like a dual LAD. You can see that there is disease that is there in the mid portion of the LAD also, as well as in the proximal part. And we did, after we pre-dilated this segment, we then did an OCT run. So we first got both the wires down, and
Our plan was
so,
basically.
yeah, so our plan was, we just want to know from you, whether any one of you would want to do an FFR for the mid LED lesion, or you all think that this is tight enough. We have Dr. Gershling, I think Dr. Nicholas is also over there. So, your views on this.
So did you say FFR? Because, I mean, the patient.
Yeah, I
who's
just
got
wanted to know
patient-
whether you want.
No.
Of
I mean, no. It's this patient
Yes.
who's got symptoms with an abnormal, non-invasive test with this sort of lesion. I think FFR would be unnecessary.
I'm talking
this-
about the
to
second
me, this
lesion,
anatomically
all.
looks more than 85%.
Right.
So I think
Right.
The real
So we
interesting
thought
thing
the
about
same.
this is
We thought
whether-
the same way.
The really interesting thing about this lesion is whether it's a true bifurcation. And to me, we'd need some other angles. I'd like to see an LAO caudal now, if possible,
Right.
to see whether or not it's a 1-1-1.
Okay. We'll show you.
To me, it looks like a
yeah.
1-1-1, in which case you have to start deciding about which technique you're going to use, and at this sort of angle,
Right.
you think maybe a culotte would be
Right.
the best thing to do. But let's
Right.
see. What have
Right.
you?
Let's
what have
let's
you
give
got
you
here?
let's give you some other angles. Yeah. Let's show you some other angles. Just show spider and LAO caudal. You have the.
Have you got an LAO
before
caudal
that.
spider view?
Sorry.
Yes, we have. We have. We'll just show you. Before
Before this, I think
You
go
had
go
that
go,
go to the-
overlap
go to the
there.
next one.
Possible to go a little
Yeah.
bit more LAO,
So-
a bit more
We-
caudal.
Yeah, show this.
Maybe this.
Yeah.
I mean, nothing really shows it,
We-
but
we
to me
felt-
this is a true
Yeah, no.
bifurcation. And I think.
Yeah, I think it looks like a true bifurcation. I agree. And the interesting thing is, most of the septals are coming from the smaller of the two, and the bigger branch is wrapping around. Looks like a huge diagonal or another LED. The septals are coming from the other one.
Yeah.
So the view to do
That's
there
right.
is
So
an REO
it's like
view.
a.
If you do an REO view, you'll see whether it's a septal, whether it's a diagonal LAD. So if you
We,
did an REO,
we'll give you an RAO just now if you want. Right. Come, let's give them an RAO view.
We'll show them what we've done.
So we'll show them. No, but we can show them we have taken an LAO caudal view in the first this thing, morning shoot mein hai. So you want us to give you an RAO view?
Yeah, I think an REO, perhaps an REO
Okay.
caudal view.
Okay.
Just,
Okay,
just,
we'll
just
give it
so
to
we
you.
can see what the angle of the lower wire is. So,
Okay. Just make a small tiny
So if
shoot
you-
over there.
that,
Yeah. RAO caudal.
Are you
It
cranial?
doesn't really.
Do you
he
want
wants
a
a-
are you cranial or are you caudal?
RAO caudal really not showing much over there.
well,
but
then
we'll give it to
REO
you.
cranial,
Okay,
but
just to
something that just separates
yeah,
off
we
the
can
wires.
show you. Right. Yeah. We've got. Let's give an LAO caudal also. Let's look at an LAO caudal. His creatinine's fine. We can make a few.
I mean, that branch with the lower
Shoots
branch
it.
definitely has septals
Right.
coming off it as
It-
well. So I think
Right,
you're
we
right,
know
it's a
that. Yeah,
dual
we
LAD.
yeah. Yeah, we consider this a dual LAD, is what we considered. We didn't consider it a septal branch per se, and
certainly
we
disease
felt
at the
that
origin of the right hand branch,
the-
the sort of diagonal looking thing.
right.
So if you pre-dilated
yeah,
the
we-
left hand one, then I think this is a two-stent
We haven't.
technique from the beginning.
Yeah, but we haven't dilated the other one. What we did was we thought that this is a 1-1 and the other one is not really very significantly diseased at the ostium. That's our estimation. So and we have significant disease just beyond. We had a ramus branch over there which is diseased, and we thought that we could go with a kind of a provisional technique. That is not to say that we would exclude the stenting the second branch, but we would not want to go for the second branch in the beginning. We are not going with a fixed two-stent technique from the beginning, but we keep our minds open to the
I mean,
second stent.
You may be right, but perhaps imaging here would help. Certainly imaging.
Yeah, we did imaging, but we didn't do any imaging into the second branch. We did some imaging into the. So we will show you what imaging we did, and you can have a look.
Brian, can you
Just,
show the cranial
show
view
the-
again,
Sure.
the PA cranial or RAO cranial?
Yeah, we'll show you the cranial view again. Just
Angio,
show the
please, angio.
just show the angiocranial view. Next. Yeah, there it is. Yeah.
So I think
Freeze it.
Yeah.
if you really, it's very the angle between the two is pretty narrow. And
Right.
if you do a provisional stenting, then you would, and if you need a second stent later, you'll probably end up doing a tap, right?
Right.
Tap
That's
for-
not
for
good
an
for
angle
the
that
for the
narrow.
angle is what
Well,
you're
if-
saying.
No, I'm just saying that if he does provisional
Okay.
stenting to one, and then end up requiring another stent later, what technique would you use later?
That I will that that's a tough one, but I would still go with the tap, but though the angle is very narrow, but I believe I strongly believe that the ostium of the second branch is not significantly diseased, and I feel that the first branch is diseased. We have disease before that, but I don't believe that the second branch is significantly diseased, is what my view is.
Angiographically, you're absolutely right. It doesn't look particularly narrow.
I don't.
And I guess
I don't think it's significantly
technique
diseased, and so
would be
yeah,
used.
yeah. I don't want to put extra metal in a situation where I'm going to use long stents as it is, and I'm going with the provisional strategy. I may not go with the if I land up with some problems, I would go with a kissing balloon into the second vessel and look at it at that point of view. Avoid as far as possible.
Can you run the
second stent.
OCT so Nicholas can comment on it here?
I'll show. Yeah, I'll show you the OCTs. Yeah.
Yeah, just
Just-
hold this angio, please.
Yeah,
just
just
hold
hold.
this.
Yeah, you
Ajit,
can see.
Ajit, if
Just-
you can see the second LED, the ostium seems to be quite okay.
Yeah,
Reasonably
I
okay,
see,
not
that's
absolutely.
why my
okay.
question is, if you are going to put in a stent, you will be putting in what it looks like a large diagonal or whatever, right? That will be stented,
Yeah,
or you are
the-
going
the-
to put
the
your
bigger
stent
branch.
in
The bigger branch.
LED. Which
The
one
bigger
are you
branch.
The
We are
bigger
planning
branch,
to-
the one which We've already put one stent in, and we'll show you that because we had
Run
disease
it.
below that. The bigger of the two
Move.
branches, we've already
Run,
put.
run that.
The lesion length was.
Here, Ajit, you can see
Yeah.
see the vessel going down, the bigger one
Yes.
in the middle.
Yeah.
Yeah. So that one, that is our target.
So let's show let's show them the OCT. Can you show the OCT? We did
Don't
okay.
let
We pre-dilated with a 2 mm balloon first, right from, and then we pre-dilated again with a 2.75 NC balloon because there was a lot of disease
Angio,
that we
please.
saw
Angio,
on the OCT.
Show the angio, please. On the screen, angio. On the screen, angio. Okay. Next. Next.
Can you show the OCT
Okay.
run?
We dilated with 2 mm first, and then we did dilated with the
2.75.
2.75. After that, we did an OCT, and Sagar, you can.
Are you all able? Is the OCT coming on over here?
No, it's
It's
coming.
just coming now.
So this is the first run. Can you run it?
Yeah, play it. So this is from the distal portion, I think.
Yeah.
Yeah, this is from the distal. There's a lot of fibrous. There's a dissection.
Nicholas can comment.
Yeah, Nicholas, I think.
Should we get Nicholas to comment as it runs? Nicholas?
Right.
Yeah.
Nicholas is
Right.
just going to the podium to give us some
Okay.
imaging insights.
Okay. Right. Right.
I'm just annoyed because it's not running. So where's the I don't
That's
have
the
the control on the OCT pullback.
Can you take off our image?
Is it possible just to run it? Yes.
Small right corner.
The vessel looks really
Rating.
diseased from the distal part to the prox part. We see some
Does that
mixed,
Can't hear it. Increase the volume, please.
mixed lipid and fibrous plaques. No real signs of calcium. You see that the huge lipid core there. And now we are in the middle AD. That was a balloon, and we see that there is a dissection. I would say that based on this OCT run, I would propose to stand from middle AD to this diagonal or second and second. So from middle AD to second diagonal to the diagonal branch, and then perform a kiss or side dilation and see if a second stent is required for a tap technique or not. That will be my strategy based on that. Unfortunately, I don't have a way to measure there, but I'm quite sure that the Mumbai team did in order to get the. But it looks it will be a long stent. Maybe 2 stents will be.
Yes, it is.
needed.
It is. Right.
A long
Yes,
side.
yes.
What diameter
Yes.
stent?
So we took we put the first stent in. We put the first stent in, which is a 2.75 by 38. The entire length came to about 56 from what we measured. But we put the first stent in. You can show the first stent where we went in the portion where we felt the disease was the least, and the plaque burden. How much was the plaque burden where we landed the first stent? Less than.
It's quite
15 or
interesting because
20%.
I wouldn't
Yeah.
automatically OCT or
Yeah.
IOS this case. So I would go by eye.
Right.
And this I think is the right length, right diameter stent, 275.
Yeah, so we used a 2.75,
No,
and
I
then
agree.
we post dilated with a 2.75, and then with a 3 in the center where we believe we didn't get we have the facility for getting images which are possible to see quite clearly, and then we post-dilated with a 3. Having then post-dilated, we measured the length for the second stent, which we are thinking of coming in right now. But after the first stent, you can show the angiography after the first stent once again.
Same honest.
Yeah.
There's something going on at the distal end of the stent.
I don't think it's, I think it's narrow. There is disease beyond that also, but I don't think
Branch
it
as
is
well.
it's a dissection or anything. Yeah, and I think we can then OCT again once we put in the second stent and have a look distal to the second stent as well, you know, to the distal stent as well.
But your distal landing
So,
zone appears to be all right, isn't it?
Yeah,
Yes.
it looks good. It
Yes.
looks good to us. Yeah. So what we are doing now is we've got a 3 point. We measured the diameter on OCT for the proximal ostial. It was between 3.5 and 3.75, and we are taking a 3.5 by 23, and we're getting that in now.
Which stent are you using, Brian?
We're using a Zions Expedition, I believe. Yeah. Yeah, just putting the guiding in a bit. Just make a shoot. Yeah. See? Okay. Let's get it on.
Go into cranial and see the overlap.
We look at IC stent or stent boost also.
Go.
Yeah. Yeah, I'm going.
Fine.
Okay. Can we see IC stent? Is it ready? Yeah. Okay.
That looks like a good, just about the right sort of overlap.
Will come on this side.
Yeah. Yeah. Okay, so this is the IC stent. Okay, stent boost you call in Philips, and Siemens calls it the IC stent. And looks like there is a little bit of overlap. Let's look at the proximal end now in both in the ariocaudal and in the iliacaudal. We want to look at I just want to look at the proximal end of the stent. You know, are you ready?
Perfect.
Looks pretty good in this view. There's the small rays. It's proximal to the small ramus and a little distal to the circumflex. And from the OCT, we could see that the distal left main was free of disease. You know,
So
quite free of
for
disease.
absolute precautions, I always go to a spider view just so I can see the origin of the
Yeah.
circumflex. It doesn't look as though it's affected
thank
here,
you.
but
Yeah, yeah, it's not affected. So we'll just take one more view of the iliacaudal just to be absolutely sure that we are
it's
okay.
good technique because it separates off the circumflex from the proximal end of the stem.
Yeah, yeah, yeah.
have to
Just
bring it
to
back.
give you a little bit of this, you know, be sure, because a large circumflex, and you know, I think this looks
good.
This looks pretty good to me. Yeah. So we'll go up
Yeah.
over here. Just be, and we can go back to the ariocaudal view, so we can expand in the ariocaudal view and be comfortable. Just one minute more. Yeah, go ahead.
Yeah. Okay.
Yeah, go to 4, 5, 6. Just hold on. Yeah, yeah. You can see it's expanding over there.
10.
Just 10. Yeah, we can take a balloon and do that then. Yeah, that's fine. Okay, we could remain a little longer. Okay. Okay, just pushing it slightly, and just go up to small pressure, not high. Just small pressure.
6.
I just made the, yeah, okay. Okay. Just, okay. Just make a shoot now to show you the, just a minute. Ready? Angiographically looks pretty good to us. What do you all think? We're going to post dilate, of course.
Then OCT?
Certainly post-dilate
Do you-
proximal end.
I would post dilate even before an OCT. I think I like to get my stent
3.5.
diameter up, a little
You
bit.
see show the cranial view.
I'll show you a cranial view. Yeah. Just a minute. There is some pinching of the.
Pinching of the branch.
There's a pinching
Yeah,
of the smaller branch of the LED.
This becomes interesting.
No question
because
about
the
it.
origin
But
of
the flow
only,
is-
the only
but this-
apprehension is, that vessel which is pinched has most of the sepals coming out of it. And there is
It has a
bit
big
of slow
sepal.
flow there. If you look at the septal, there is a little bit of
We-
slow flow.
We'll give you some medication and we will once again assess it.
No, because
Are you ready?
yeah. Flow is good.
I think the flow is not slow, Ajit. I think the flow is adequate.
Better.
There is
First angio, it was looking little slow.
it's yeah. That happens, occasionally. Now my point to all of you and ask your judgment over here. Would you want me to recross this vessel, or would you want to just post dilate the proximal segment and leave it simple?
Before you rewire anything, you should post-dilate. I mean, it just stops you getting any
Yeah,
wires
yeah.
behind this stent struts. Causes all sorts of problems. Sometimes you don't
Right.
even know you're behind
Right,
it. It's
right.
too late. So I always,
Right,
I
right.
always pop
So I-
before I rewire anything. As a principle.
So
I agree.
we're going to, yeah. So we're going to, just no. No, I just want to hear you once again. You would pot first now before the
Yeah, definitely-
before you
definitely
rewire.
pot. Definitely pop first because it just
Well,
stops you
but-
getting your wire behind
Well-
the stent struts. Well, it doesn't.
No,
stop
but
it.
would you not pull this wire out now, which is there
Can you-
behind
No,
the stent?
Don't pull the wire until you've
No.
rewired. So pop, rewire, and then pull the wire if you want.
I generally do it the other way around. I
Yeah.
generally pull the wire first, then do the pot.
Yeah.
Yeah.
I
That-
don't know
that's-
whether it makes
yeah,
a difference, but that's
that-
what I do.
I also
I understand.
I also do that by and large. So is it different with both of you, Nicholas and with Anthony? Is it different that you would now pot
I-
first and then
Yeah,
then
I
rewire?
I definitely agree with Anthony, and in France we pot first, always, because
Right.
then it makes the recrossing process of the distal cell easier. And
Never
Okay,
means it's
okay.
the last pot, but it's the pot before
Well-
you rewire. I've seen a number of cases where
Well,
the wires got behind the stent strut.
No, I totally
Yeah.
agree that you pot before the rewiring, but the question is whether you would pull the jail wire first or not.
If you pull the gel, gel wires being properly gelled after potting is very uncommon. It's more common if you have the wire like this between two stents. But the point is that if you pull the wire and it's stenosed, you may lose the vessel completely. So it acts as an identifier
Yeah.
and a marker for where you're going to recross.
Nicholas,
there's a question
my
in the
point
room.
is why?
Yeah, just Dr.
Nicholas, my
Banerjee here.
point is why can't we?
Yeah.
Dr. Banerjee,
Yeah.
before you ask a question, one point. Dr. Nicholas, so why don't we pull the LED wire out and recross into the diagonal? Why don't we extend the wire and then we can sort of do the post dilatation? How about that?
I don't think we have, without doing a pot, I answered your question from my end. without doing a pot, you can really make a good final bifurcation. So that's the take home. If you want to pull out the LED wire at this point of time, you are not sure that you are going
We're
to
talking
go
about
through
the smaller.
yeah, smaller branch, going to the
Yeah.
distal start into the smaller branch, and smaller means it is a big branch which is adequate septal, the narrow
But-
angle 70 degree, less than 70 degree with the ostial pinching. So, and I don't think we have crossed a calcified segment of the proximal LED where the chances that it will be very difficult to retrieve this gelled wire. So probably we do a
Okay.
4O balloon and do
Okay,
a good
so we
spot
will,
and then take out.
we will take a. Okay, you got a 3.75 by 3.75 ट्रैक है
Get a
4O
Okay.
किसका है ट्रैक का है small short 4O
Whilst they're doing that, I think 375 is fine. I think the
I-
final
I think a 375
you're
is-
really anxious about this.
yeah
Put a dual
3.75
lumen
8.
3.75
You put a dual lumen
Yeah.
catheter down one.
3.75
and the
eight.
other lumen to wire the branch, and then you've never got behind the stent struts. Yeah. We keep suggesting things.
3.75.
What are you planning to do?
we are planning to now pot, okay, and then we will recross.
That should be fine.
Yeah, that's fine.
10 is enough.
Should ask the panel what's their criteria for dealing with the ostium of the left-hand branch, what we call the small
Well,
LAD.
I mean, when you do provisional
What's the
stenting,
decision
if
making?
patients, if the flow is STEMI 3, if there are no ECG changes, if the patient is hemodynamically stable and asymptomatic,
With the stenosis as
with,
as
with a stenosis, in provisional stenting, it is suggested that you just leave it alone in that situation. But for this
Show me in
particular
caudal view.
patient, I'm more worried because of the large septals which are coming out of it. That makes it a very, very important vessel.
so what are you thinking? What are you thinking?
Well,
Put you on the
I
spot.
would probably, if I recross, I'd probably do a tap.
Stent it? Would you balloon it first and see
Balloon
what it
first.
showed? Would you
Well,
ibis it?
actually, you can balloon it first and see how it looks.
Would
If
you ibis
if it looks absolutely
I need
fine,
to see it in the.
no
Now
residual
I need to
narrowing,
see it in the
But
other.
I see
pain,
the
no
ones.
ECG,
I see,
everything
but I want to
is
see it. I want to see it.
fine.
In,
Doesn't leave it.
yeah. Well, but first I'm going to do
I
an
fully
ICU
agree
view.
with this attitude and this strategy, and I think that first we have to reballoon and see how it goes. If there is no dissection, no residual chest pain, no EKG change, and TMI free flow, I think it's good to let it like this.
So, Nicholas, what is any stenosis
Go to cranial.
acceptable?
Go to cranial.
So, I mean, these are decisions we make every day, and that's why we're here on the panel. So, what stenosis is unacceptable in the origin of this
Just-
left-hand
It's supposed to
LAD?
over 80% of stenosis. I think
we'll go on this
it
thing
should be
again.
at least
I
checked.
see.
I mean, when I really wonder about a side branch stenosis, I use FFR.
Yeah, the ripcord study, of course, done by Nick Curzon in Southampton, looked at this.
You're till the
And
right
you
upper,
could
right
do
upper.
Pretty good.
FFR
Ready?
into the
It's
side
done.
branch.
Yeah.
Yeah.
If you reopen the
Once
Put
it
it
balloon-
balloon.
And more often than not, in side branches which look stenosed proximally, their FFR turns out to be negative, right?
Ready.
I followed some of these up. I did nothing and came back usually diagonal.
Are you ready?
So they come back,
Huh?
give them
Right
a
upper.
trace, dive the toes away a bit, bring them back. So I brought a few back. I was concerned about no big those was bad.
Okay. Okay. I think
Yeah, go.
we go up here. Let's go to 8, 10, 12.
We have strategies. It's not going to happen here. But do we have strategies for gelled wires that won't come out? So there's one wire you must never gel. That's the rotor wire. You gel the rotor wire, the tip always comes off. Yeah. So I never gel a rotor wire. That's
The rota wire, yeah.
That's
Yeah.
absolute. So that's one wire for the young people who should never gel. So
Okay.
what do you do?
Cross.
ready
What's
to
your
see.
strategy for the wire?
Just make a
that,
shoot first.
Well, what we can do if it's completely gelled and not
Yeah.
removable, it's worth trying
gonna
to
take it
use
out
a
and
very small balloon,
this
like a
with this one.
1.25, go under the stand and
there
try
it
to
is.
remove the wire
Hold on it.
on the
Hold it on.
gelled wire on the balloon.
I'm going to come on. Yeah. Yeah.
Right.
You come back to
So
coordinate.
that was a little bit tough. It's interesting they've taken the wire out before rewiring.
Yeah.
So if you do that, Nicholas, it's really important that you put a balloon, undeployed balloon, in the main stem, because when you put your 1.0 or 1.25 balloon down beside the stem, you can disrupt the struts and never get a balloon back.
Absolutely.
Okay. Now come to the view. In the view.
Any comments from the audience? Who would have left this so-called gelled wire in place before rewiring? Raise hands.
No.
Who would have
electrical,
taken
I
the
think
gelled
go to
wire
electrics.
out before rewiring? Okay, so that's 3 people. 4 people. 4 people in total. Is it possible to have these lights down so that we can see some of the audience, please? Our lights down. It's very, very bright. No, we need these top lights down because it's harder for us to see the screen.
I need another view.
Spider, give me the spider, please.
Yeah.
So this is going well, but you know, it does act as a marker, that other wire.
Brian, which wires are you using right now? Guide wires?
See, I have the hypercourt down the LED, and I have the Renato. You know, this is a Renato actually. Yeah.
No, show us a proper spider place.
I want to take an angiographic shoot at this point, okay?
Who is
A nice
spider? So
angiographic shoot and look at what exactly is happening with this side branch now, you know? So just let's get back to the LAO view. Why are we?
Can I get a 40, 30 LA grenade?
Yeah.
Just
I
go
just want to
45.
have a look at the, you know, the side branch and whether I've got good flow down it. Okay.
This is a good view.
What does anybody else want to do now? You want to rewire it really?
Actually, I would definitely rewire it. There is no question, because that lesion looks pretty
Why?
significant. That lesion, well, actually, if it was a diagonal and inconsequential branch, I would have left it. But this is not diagonal. This is LED, proper LED. It looks small, but it's proper LED.
There is definitely a significant amount of myocardium that is perfused by this artery.
The vessel that goes to the apex
Okay.
is the one that's been stented. And
So
so
are
we're into
you
definition of an LAD here.
So are you
If it
suggesting to
thinks
me
important,
that I need to do a kissing over here?
Yes.
Okay.
Okay. Who in the audience
I'm
would
not.
leave this as it is now? Hands up. 1, 2, 3, 4, 5. Who will rewire this now? So it's about equal. It's almost like a Brexit vote.
I'm going to do what I'm going to do. Yeah. So I'm going to leave it here. I don't think I'm worried about it. I'm quite. The Timmy 3 flow is there. I'm going to do an OCT of the main vessel, and I'm going to show you the OCT. I'm not worried about it.
Are you going to give us an OCT of the main vessel, get a glimpse of the
Yes.
side branch?
Yes. Yeah. I'm going to give you. Yeah. Sure.
So hands up in the audience who uses OCT regularly in their cath lab. Who uses
I'm not
IBIS?
going to worry about that.
again, see if there's question there.
Yeah, question is he didn't post dilate the overlapping segment. I mean, he just did the part only.
No,
That's okay.
we are coming.
That's okay. I'm gonna do that afterwards. I'll see.
But you know that you will be safe by wiring the the septal, big septal.
Anthony,
Let me
what
first
will-
do the OCT.
Anthony, what will be your strategy in case you cannot recross with a wire? Do you have tips and tricks to provide just to get easier
Yes,
and the
just
side
come.
branch?
So if I can't recross the wire, I might use an angled fine cross, yeah, which is a nice little catheter, not
Yeah.
like it.
Okay.
Come a bit further. Yeah. Okay. Yeah. Let me just see it on.
Little angle on the
s-
end of it, and that can sometimes.
Yeah,
work
I think I can go down a little bit.
at
Yeah.
Put
A
the
little bit
guide.
more. Yeah.
No. Put the
I
guide.
mean,
guide.
guide.
finding the right angle and getting the tip of the wire must never be more. The bend
Okay.
in the end of the wire must never be more than 1 or 2
Huh?
millimeters.
Cross.
Yeah. What are you doing?
Calibrate. You calibrate it.
Yeah, calibrate it. Purging.
OCT बताओ.
Okay.
OCT. Again side से first. Tell them to put the OCT here.
I'm going to go down a little bit more. Okay. Are you ready to go? Let me see the guiding first. Let me see the guiding catheters in properly. Make a small shoot. Okay.
Yeah.
Are we at the correct side from the?
Yeah.
Okay. Are you ready?
Yeah.
Okay. Yeah. Okay. Sure.
First pass, it looked good.
How many people use an injector for injecting, and most people inject with hand, or
Just run it, please.
they
Just
use
run
the
it.
injector?
Sagar, I
Run
wanted
it
to run
first.
it first.
Run it.
Hands up who uses their hand.
What did you use, Brian? It was hand or injector?
We
This is
hand.
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 Nicholas is going to go and do the 3D.
Yeah.
So Nicholas, can you ask them for what you want to see? Do you want to see 3D?
Can Nicholas
Yeah.
comment on this?
So it's
Dr.
true
Nicholas,
that
can you comment
on this
3D
one? He's gonna
reconstruction mode with bifurcation analysis to
Yeah, we'll do it.
identify the overhanging struts on the ostium of the distal
Yeah.
LED.
We'll do that just now.
It should be there.
Most of the stent looks well opposed.
The deposition and the expansion of the stent looks good
Yes.
Yeah.
here.
I don't see any red marks anywhere.
No, that's okay. Let's see it properly.
Except for the here.
Yeah.
Except for this part.
Yeah. There's a branch there, I think. That's not.
You see the circumference.
Just show us the whole. Show us the
3D by?
3D construction, as well as show us the diameter we've achieved. And, yeah, that looks opposed. Yeah. Can you all see the 3D fly through? Is there a? Yeah, Nicholas wants to comment over here.
I think could you change your 3D analysis mode because
Can you change the mode of the?
yeah, dedicated to the bifurcation.
Yeah.
once again, I mean,
See the bifurcation.
Bifurcation, yeah.
expansion and the apposition looks very nice. I think that the overlapping zone between the two stands is very short, but there is no gap as far as I. So
There it is, very short, but no
yeah,
gap, yes.
that's a very nice job. And now, if you get more proximal, I assume that the ostium of
proximal,
the
More
LED
proximal,
should be
please.
between 40 and 60 millimeter.
Come more proximal, please.
He's doing that.
And
Bring the
now
cursor,
you
please.
can click on the third item, the bifurcation mode. Okay.
No, you want to see the
You want to see
LED,
the
LED proximal LED.
Yeah, we see
Proximal
the
LED.
overlapping
Yeah.
zone there, and it should be there.
Yeah, that's the,
there.
yeah, that.
Is this the remus or?
No, that's the second one is the,
So,
that's the rim. That's the circle.
This-
That's the circle. That's, yeah.
this is probably not.
What about
help
the-
us very much, I don't think.
No, this is not the,
So let's have another. We're going
Yeah,
to
I
have
want
one
to
more
see-
angiogram because I think
Yeah,
we're running
no.
out of time.
show the,
Try
show
and
the, show
remaining
the,
8 minutes,
the
sorry.
bifurcation mode for the, by turning the thing for the dual LED, no? That you show. I'll remove those, yeah. One, minute, let me do that. Yeah. Yeah, take this out. Shows the bifurcation mode for that area which is the,
You can see the
Thank you.
ostium of the LED.
yeah. Yeah.
Can we see the ostium of that jail branch?
Yeah, the branch.
The branch. Can we see that?
That's there, that's there, there it is. Where that one red dot you can see going towards the branch, because any branches you'll always see some part of it which is, yeah, just play that to the point where,
The overall stent is pretty well opposed, good size, and I think there's probably anything more to do to the main
Let's-
vessel.
So
let's make an angiogram and
And interesting,
Sure.
the distal end, the very end of it looked good also, but where I was a bit concerned earlier on, down by,
right.
on the far left-hand end, you can see it's.
Ready for
where
good
it
angio?
goes to bend.
Yep. Look at that, Ajit. Yeah.
It's
we need to
slightly
put
different
that
view.
in,
I mean,
just before the
Yeah.
Yeah.
I mean, it's
We
little.
can we give you that is a PA cranial. Let's give an LAO.
yellow cranial.
Let's give an LAO cranial.
What is that?
Yeah. Yeah.
What
flow
is
is so good.
Yeah.
It's, I think you're
Yeah.
pushing your luck to start fiddling.
Right.
It looks little better than before, but still there is
Okay,
hammering.
vote from the audience.
but I think
Hands
we-
up if you're going to pull your wire, go home and have a cup of tea.
I'm going to have a cup of tea.
You
I
can't
don't know about
vote.
the
You
audience.
can't vote in the lab. If you- hands up if you're going to
I'm just-
rewire this other vessel, this non-wired vessel. Nobody.
Yes, dilate below
Nicholas,
the
you nearly put
blade.
your hand up.
Yeah.
So there's
Yes.
one, Nicholas.
I think
An extremist.
excellent result.
So, what are you're the guys in the lab. You're at the front line there. What's your plan?
My colleague over here, Dr. Anand Rao, says I need to still dilate some part of that stent, which he sees on stent boost. But I'm thinking I'm not going completely by his advice. I'm just going to hold
at
on
least
a little.
at least at the angle where it's
At the angle
overlap,
maybe, at the
at the
angle,
overlap.
but just below the, we may go at the overlap and I'm going to dilate at the overlap, you know. I'm going to dilate at the overlap of the segment, just that. I'm just going to do that and I'm going to come out.
I think you've had an image that
Will you all
shows
agree?
that the main stent looks great. I think that
It's-
you have
it's
an
good, I think.
angiogram that says there's good flow in the side branch. I think if it was me,
Right.
I would stop him and
Or
I
stop
would
it.
stop. I would also stop actually. I don't know why yeah, I'll take another picture in 2-3 minutes time. I'm going to pull this wire out and I would stop, honestly.
You just did.
I like what I got. I'm not going to get more greedy. Yeah.
So let's see if we've all made the right decision with you.
We have 7 more minutes to go, Brian. Want to tell us anything more?
We can discuss.
Yeah.
I'm
could do the right
basically a
coronary
guy
artery.
who the right coronary artery is normal. Is normal. I am more in. I don't think provisional stenting actually means a one stent technique. Provisional stenting actually means the option of going with a 2 stent or a 1 stent. And there's some situations where I go directly with a 2 stent technique. But in most of the patients, I go with a provisional strategy. Has been my kind of approach, unless I'm talking about 2 very large vessels right from the beginning. Maybe they're at least 3/0 each, and then I go with a two stent strategy, and may go for DK crush sometimes, depending upon the angle, or may go for a culotte at times. But when I go with a provisional strategy, I then have the option of either doing a tap, or at times even doing a culotte or a inverse crush. But I prefer, because metal is a lot of metal sometimes, and unless the 2 vessels are really large, then I go with a preferred 2 stent strategy. What's your approach?
So there's a number of things that are quite interesting. Provisional still works against all the other trials, in all the trials against 2 stent strategy. Some of the issues relate, of course, to poor techniques in the 2 stent strategy. Double kiss crush is, I think, a laborious and long technique, but seems to be relatively robust. The European Bifurcation Club are about to start or started the left main stem bifurcation in true bifurcation 111, and that's important because unlike this vessel here, which is a relatively unimportant vessel, we saw that as a stenosis first time out, we wouldn't go anywhere near it. But in left mains LAD circumflex, that's obviously
Yes.
a very different
Yes.
issue and needs to be addressed. There's a question
That's a different
from the
issue.
audience. Sorry.
So on the angiogram, the proximal stent appears to be underexpanded compared to the distal stent. If I had not done any OCT or
Should
anything, I
have-
would definitely post-dilate the mid
I would
segment.
definitely put
Yeah,
Expanded.
yeah. But
What
after
was
I
the
saw
minimal
after I
lumen
saw
area on the OCT?
Yeah. Sagar, can you tell us the minimal luminal area in the proximal part of the stent? Yeah. No.
I think you've
Yeah.
done a very nice
Just-
job here, and
You can just
I
tell
think
us.
make
Tell us
sit-
first in
make
the
your-
absolute proximal, and then tell us a little bit.
6.48 is the MLA.
Is-
Doing simple things well is really important. I think you've done a really nice job.
7.76, 7.76. I think it's pretty acceptable. I think it's important to get vessels TIMI3 flows and do it well, and keep strategies simple. They kind of last longer in my opinion than some of the very technically demanding. But we do them. We do double crush case quite often when we have
So-
left main bifurcations
So
and
the
things like that. But
choice of
I didn't think
techniques
that
around
that was necessary.
bifurcation come down to a number of things. They come down to the angle. So culotte
Right.
is not good at a very
Right.
steep angle. Tap or
Correct.
or spot stenting at the origin of the side branch is very good at that angle. The size of the vessels, if they're different sizes, then culotte's not a good technique. If they're the same
Culotte's
size,
out
and
if
this,
you
if
have-
you
yeah.
were to do this, then I think culotte would be a very
Right.
good technique. It's very safe, and the carenas is well covered and reconstructed.
It is better to get well versed with one technique for provisional and one with dedicated 2 stent, and get familiar with with the two techniques. That's the best approach. Before we close, I would like to request Dr. Ambile to comment upon the OCT part of the case, whether he thought it was adequate, whether something else could have been done, or this is.
No, I think they did a very good job, and I think that especially when you deal with very long lesions, it's very important to have pre-PCI OCT analysis and post-PCI in order to once just to correctly size your stent and then to control that there is no under-expansion, because the longer the stent is and the higher is the probability of having under-expansion.
So in this case, you think the result was adequate and perfect, or?
I was not able to make the measurement, but it looked what I saw so far, it looked good to me.
So Nicholas, if this wasn't, I think this is right for a live case to do imaging. If this was your case in your lab, and would you have used OCT or IVUS?
Yes.
Who in the audience routinely would have used OCT or IVUS in this case? Okay. So that's why you're here.
Sir,
One, we have a question.
what do you think about the role of cutting balloons
Okay,
in provisional stenting in these cases?
Pardon?
Use of
Okay,
cutting
okay,
balloon
okay.
when our
We-
strategy is
we'll
provisional
put-
in these
just put
cases, like
give him
doing a
something.
debulking, especially in the main branch
Yeah.
and sometimes in
You-
the side branch with a cutting balloon or a scoring balloon.
We're giving you something.
Will it give some better results?
In this case, or generally?
Before putting in a stent,
No, no.
there's no role of
You
cutting
need to
balloon or
put in my
scoring
ear again.
balloon.
Well, there is. I mean,
I don't know,
there
you
is.
bet.
What I do is if I get there's any suspicion of calcium on the angiogram, then I will, if I can, do IVUS to see how circumferential it is, and that will help me decide whether or not I'm going to take a rotablator or even shockwave therapy. So I think if
Just come and
I
fix
don't
this
see
on my-
calcium on the
You can continue your comment. I would just like to interrupt and stop this session because the satellite time is over. Thanks, Dr. Brian, for the excellent case.
Thank you.
Thank you.
Thank you, Ajit. Thank you very much. Yeah. All the best. Bye.